You're on mute, Martin.
See, Andrew, I'm just following your instructions. I'm going on to mute all the time. And you're going to launch the polls now, are you? Once we've had a chance to look through this. So we're going to do the polls. And you're going to launch them, are you, Claire, or is that Andrea?
Yep. All right, bear with me if the tech permits. It's just loading. Okay, here we go.
So we've got 4 polls today. So this is just to kind of set the scene and see who's here and if they're using FeNO. So would you like to click on the poll to say which FeNO device are you using? Are you using the bed font? Are you using the Circassia? Or it's okay if you're not using FeNO yet as well. You're still welcome here. It's just we're just doing this just to find out.
Can everyone see the poll? Has it come up on the screen?
Oh yeah, we can see we're getting answers in straight away. So we've got, that was very quick, 7 responses in. We have 20% people using bed font, 40% using Circassia, and some not using FeNO just yet. So thank you for that. We'll go on and do the next one.
Okay. Can you all see that one?
Yeah, that's it. Thanks, Claire. You're doing a great job of launching these. She puts them all ready for me. So for anybody that's using it, do you think that the FeNO test is easy to do, easy to perform? So you've got just 3 options, yes, no. And if you're not using it, you can obviously put don't know. Although I should add that there is a short video on the West Midlands website done by Dr. Ian Cliff, who came to our first collaborative, who runs through how to do a FeNO test from kind of the patient perspective and the clinician perspective. So worth popping on there. So let's see if we've got any results. Okay. Well, that's really good. So nearly 60% of the people using FeNO think it's very easy to use, which is marvellous. A few said 10% to 8% said they don't think it's easy to use, and maybe we can discuss that later on. And 33% don't know because they're not using FeNO just yet. Okay, thank you. Move on to the next one.
Here we go.
So we're just this time we just want to find out how many tests you've done. You know, if you've done an awful lot, have you just done a few? If you want to submit your response, and we should see that's come up as a little cloud as everybody fills in. So we've got somebody's obviously done no FeNO test because they've probably not got a device just yet. We've got somebody who's just done a few, which is great. It's all getting started. We love it. And the biggest number we've got at the moment is 100 tests. Still coming in. So the range is still 2 tests to 100 tests, but we've got like 30, 80. 8 is great. 30 is great too. Brilliant work. Because it actually, at the beginning, it takes a little bit longer to get going with this. And we know you've all been extremely busy with all the pressures in primary care at the moment. So, okay, we'll move on from that. Thanks, Claire. We'll do the next one. So if you haven't got FeNO yet, are you interested in adopting FeNO? Oh, brilliant. So far, really high response on that. So 80%, I was going up again to 88% would like to adopt FeNO, which is absolutely brilliant news. So great that you can come here and find out some more about it. So the last poll for this session. So we're just asking how you're using FeNO. Are you using it for just asthma diagnosis? I use it in asthma management. I use it in both diagnosis and management. And For those who haven't got the device just yet, neither. So again, thank you for your responses. Brilliant again. So we've got 47% using it for diagnosis and management. And obviously a group of people who haven't got FeNO yet, and some have just used it in diagnosis so far. So absolutely fabulous. Thank you so much for giving us all that information. It's really valuable and really useful. Martin, over to you. Did you want to just go back through the agenda, Claire? Do you want to just go back a couple of slides and we'll just do that before we...
Yeah.
Thank you.
Fascinating polls. I do like the kind of number cloud as opposed to a word cloud. I think that's quite an interesting way of displaying some of that. And it's interesting information there. And we'll share those results of the polls with you if we can. So I think that's quite useful information. So great pleasure today. This is our second webinar. And rather than actually having people talk about the science of it, today we thought we wanted to talk more about the practicalities of it, warts and all. So we've got some great experience to tell us about how they've used FeNO. And the first speaker today is Bev Bostock, known to many of you, I'm sure, who's an advanced nurse practitioner, but also sits on ARNS as the asthma lead. So lots of experience here. So Bev, really looking forward to hear what you've got to say about FeNO, its place, and as we said, warts and all, eh?
Definitely. Yes, I will tell it like it is, or certainly from my experience. So really good to hear that people are interested and already using FeNO. And I think, you know, we've got time for questions and answers, but I would actually say some of those answers may well come from those people who are already using FeNO, you know, because you can really support your colleagues on the call today to understand what's happening in real life with your use of FeNO. And that's pretty much what I'm going to try and do here. So no slides, just me talking and taking you through why I did it, why we did it as a primary care network, and what it's done for our asthma care in a broad sense. I also came from the perspective of, so if I just put my different roles out there on the table. So I work as an AMP in long-term conditions in a practice, but I also work separately in a different primary care network with 3 practices that work independently. But my role is as a lead nurse for long-term conditions, looking at issues such as respiratory, heart failure, diabetes, and trying to make sure that we're offering the best level of care that we possibly can from the nursing team. So I was already using FeNO in my own practice and had been for some time, even before it became, you know, quite fashionable to do so. I thought it was really interesting test to consider. And I think sometimes something that for me is really such a basic thing to understand about the role of FeNO is something that isn't always made clear, that when you are trying to assess somebody's respiratory health, and you talk about tests like spirometry and you talk about tests like peak flow monitoring, what you're actually looking at there is the movement of air in the lungs. With spirometry, you're looking at lung capacity and then also the movement of air in the lungs. With peak flow readings, you're looking at what happens in the first tenth of a second of a blow. So it's very much about the movement of air. And so you're looking at what might be happening in terms of that air movement. Whereas when you look at FeNO, remember fractional exhaled nitric oxide, we're looking at a marker of inflammation. And so when we think about asthma as being, for most people, in the most part, an inflammatory condition, with FeNO, you've actually got the potential to assess how much inflammation is going on in those tubes. And that for me is really important, because actually we've got a double whammy going on there. We can really look at different elements of what's happening within the lungs and make a much more informed and educated decision as to, you know, what the diagnosis is, but also how best to manage that individual going forward. So once I sort of got that in my head, it seemed to me that it was a really, really important test to have available to patients. And that's why I'd brought it into my own practice. But when we looked at the primary care network, we realised that there were quite a few issues that needed to be addressed. Clearly, post-pandemic, there were issues around spirometry. And so access to spirometry was very limited, and, you know, still is, quite frankly. We've still got major issues around providing spirometry in primary care in many areas. We're very, very keen to develop these diagnostic hubs or hublets, depending on the vocabulary you prefer. And yet, you know, we all think it's a great idea, and yet in many areas of the country, it's still not happening. So people are still being left to their own devices in primary care to decide how to make a diagnosis, how to decide how well that patient's being managed. And that means that, you know, if you're looking at evidence-based care, there are some significant gaps, and that was certainly the case within our primary care network. We had one practice that had somebody who was fully up to date on the ARNS register, and that's a debatable issue in and of itself. Maybe we don't go down that route, it's not necessary, but she was, and that was the exciting bit, that she was already on that register. And she was able to do spirometry. They'd got everything in place with all the infection control that was initially needed because of the extra threat that came with COVID. She'd always been very good on her infection control, because, you know, we should remember that COVID wasn't a new development in terms of infection control. We should have been doing these things all the way along. But she was really up and running, doing spirometry. She got a healthcare assistant who was also doing it. She was great with interpretation. Happy days. So that practice were fine. Another practice had a machine, but no one was using it. That was spirometry. And the other had no machine and no staff. So the whole issue around how a diagnosis was being made when patients present with symptoms of a respiratory nature was a big issue around access, around health inequalities. So there was another agenda playing a part there. So we recognised that there were some issues that needed to be addressed, and we believed and do believe that FeNO actually helps to plug that gap, because there is some debate around the place of spirometry in the diagnosis of asthma. A lot of the great and the good would argue that it has probably less of a place than it does in chronic obstructive pulmonary disease, for example. And actually, FeNO, looking at those measurements of inflammation, along with some really good peak flow readings, could actually be the way to get a real good understanding as to what's going on in the patient's lungs. So we wanted to be able to offer more than we were offering at that time. And really interesting that so many of you said that it is, I think most of you said it was an easy test to do. Be really interesting to ask patients whether they agree, because certainly my feedback from patients in my own practice and within the PCN project is that they can't believe how easy it is. They are actually blown away, especially if they've done spirometry in the past, and they come in with a sense of dread at having to do spirometry. And it's like, here you go, this is what you do. This time, oh, thank you, very nice. And they love when they get a big tick telling them that they've done it right, and they're so excited that it was that simple and straightforward. But it could really help us to be more confident about the diagnosis that we were making, and also if we needed to adjust the treatment that the patient was on. And that could sometimes go in two directions. So sometimes you get those patients who are inadequately treated, and we could demonstrate that through the use of FeNO, and we could really sort of accelerate their move on to the next level, or even a referral into secondary care or a severe asthma centre. But similarly, it gave us the opportunity to think about patients who had been diagnosed during the pandemic, might have been on the register as suspected asthma or coded as suspected asthma, who really needed us to start again with considering, was this right? Was what we had done correct? Did we actually need to backpedal a little bit and reconsider what we were doing? So really good opportunities to improve diagnosis and management, really good opportunities to address health inequalities, really good opportunities to improve patient education, and also I would say healthcare professional education, because people suddenly understood the role of inflammation in these conditions. And so patients who thought that they were doing fine, despite the fact that their asthma control test had you going, oh no, and they'd still tick the box to say, my asthma is completely controlled. You're like, no, seriously, it really, really isn't. And you could actually measure the level of inflammation and explain to them, you know, where they were sitting, that they were still showing evidence of inflammation, and that was driving their symptoms and their use of their short-acting bronchodilators, although many of you will know I'm definitely a MART girl at heart, so definitely the way to manage asthma as far as I'm concerned. But, you know, extra doses of short-acting bronchodilator is not what we want to see. People still think it's the norm. This is how I manage my asthma. And so being able to say to them, you know, this muscle relaxant that you're using to try and manage your asthma is not actually treating the underlying problem, which is the inflammation. So they got it. They actually got it. They could see the numbers. So it was really useful from that point of view. So when we actually tried to implement it in the primary care network, what we did is we put in a bid, and I'll be honest here, I put in a bid for 3 machines, because we've got 3 practices, and I thought, you know, if you don't ask, you don't get. So I asked if we could have 3 machines so we could put them in each practice and use them accordingly. And I was delighted that our bid was successful, albeit for 1 machine. So we only got the 1, and I don't blame. I don't feel bitter at all. I recognise that this is a limited resource. So we got 1 machine. That's been interesting, and I still think that I need to get to grips with how we share this machine fairly. So we have decided that one of the ways that we might do this is actually to have 1 nurse going from practice to practice and using FeNO appropriately. And some of you will have seen Carol Stonham present on the last meeting, and she has for a long time been a massive supporter of FeNO and has actually run FeNO clinics in Gloucestershire where people could just book in and get their FeNO done. So we decided that maybe that's the better approach, that we have these FeNO sessions within practices where people can come along and get the FeNO test done. We can actually get through quite a lot of people, or they can book in for a really full holistic review with that nurse to get everything done so that we tick all of those boxes at that time. So we're still sort of playing with that. And it's been like, funnily enough, I've got 3 practices and I've got 3 children, and it reminds me of when my children were small and trying to get them to share and be fair about who had what for how long. So we're really trying to work that out at the moment. But also what I'd recognised is that there was some important collaboration going on at a national level with 2 groups that I was involved in. One was the working group for FeNO, and the other was the working group for severe asthma. And we realised that actually there was an awful lot of overlap between the work that we were doing. And if you haven't seen the resources that are available for both of these things, you absolutely need to go and have a look. So we've got some really excellent FeNO modules on the e-learning for health website, talking about what it is, what it tells you, what the measurements mean, how to interpret, even when to use it, because as marvelous as it is, I'm not sure that every patient needs a FeNO test. And I would go back to what I always say when I'm talking about diagnostic testing, which is the most important part of any diagnosis, is actually your history taken. So a really good history taken along the lines of, I think the BTS sign guidelines have really good recommendations about what should be covered when you take a history. Take that history and then decide which tests are most appropriate for that patient, depending on what you find there. But we recognise that the information that's on the e-learning for health website, all of the stuff about how to do FeNO testing, the stuff that you can access through Pulse about severe asthma, which is also really important. There was a lot of overlap between the sorts of patients that actually just might be uncontrolled. So that these patients might be uncontrolled because actually they hadn't been diagnosed correctly, or they were uncontrolled because they weren't actually being managed correctly. And that if we worked across the sphere of good history taking, spirometry when indicated, peak flow readings, FeNO testing, we could actually manage the majority of people very effectively. We combined it with an impact and investment fund approach to reducing the use of metered dose inhalers where appropriate, because I know that people can get quite feisty about this topic, where appropriate. So move into dry powder inhalers, and actually again really encouraging people to think about maintenance and reliever therapy as often as possible and where appropriate. So it became a bigger project, but FeNO really underpinning a lot of the decision making as we went forward. So I think that we need to recognise that this is a powerful tool that can actually roll us into other areas that we need to focus on with our respiratory management, from diagnosis to decisions about the approach to treatment. So, most of us would agree that if somebody has a diagnosis of asthma, they need an anti-inflammatory. How they take that and when they take that may differ, especially if you look at the GINA guidelines on managing asthma, which are quite different from the UK guidelines, not least because of licenses. But, you can actually get in there and manage a patient appropriately based on the information that you've collected through all of these routes that we've talked about so far, and end up with a population that are well managed on treatments that are good for them, good for the environment, give them control over their own condition. I mean, so many boxes ticked. And all beginning really with us applying for our FeNO machine. So it's really opened up so many opportunities to improve the care that we offer to our patients with respiratory conditions. There have been challenges. I will never be the sort of person to go, yes, it was dead easy and everyone's really happy and we're all, I've already said that sharing has been an issue. But also, I think the data collection is going, and it's so important with any project that you do, that you think about, what impact that has had and how has that improved care. And I remember seeing Kerry Mills presenting on the last session with some powerful data around, what they'd done with their FeNO, not least in terms of saving money, because often people think, oh, you'll end up doing more work as a result of this. She actually was able to refine their workload and actually streamline it, and then end up with financial savings as well, which was astonishing, I thought. So if you didn't get a chance to see that, there are recordings available. So you can go and have a look at that. Really interesting. But I think generally speaking, everyone's been really excited about it. My biggest challenge has been making sure everyone gets to have a go with it, because they all complain about not being able to get it on the days that they want. It does make you think, do you know what? We really should just invest and get some more of these out there. And I know there's going to be talk about FeNO machines and access to them a bit later on, so I won't preempt that. But I wonder if to pause there for a second and see if anyone has any questions, comments that they would like to ask. I can see things popping up in the chat. So Martin, I don't know if you've got anything you want to highlight to me. All right, so I can see the one from Lisa there. Oh yes, so we've got a nice link there. That's very clever, isn't it? I know that's like having an amazing wingman woman. So yes, this oh Lisa, oh dear, don't get me started on quaff. Oh dear, yeah.
So a question appeared and then the hand went down. So there's a few things coming through in the chat. Have you got more things you want to say, Bev, or do you want to carry on?
I was just noticing that that Lisa had mentioned there about cough, and I think it is an important question, isn't it? That you know, cough is on this occasion. I have been a long-term critic of quaff. Let's put my cards on the table. I think it makes good clinicians worse and bad clinicians better. And if you happen to believe that most people are good clinicians, then that doesn't really work very well. The need to do spirometry to tick a quaff box is deeply frustrating, and many of us would agree that you know, we had this debate at the Primary Care Respiratory Society conference recently, and you know, taking away that clinician autonomy to make the decision about what is right for the individual patient is very frustrating. So yeah, there are ways and means. Which probably Lisa, just email me and we can have a little chat about this. Always happy to share my email address, which is just really simple one. It's beverly.bostock@nhs.net. So do contact me on that. LEY at the end, that's the bit that people miss. So that's what I was going to say there. And yes, I would say there is real potential to do that, Lisa. That's one of the things I would say. But maybe that spirometry discussion is for another time. Maybe we focus on the FeNO side of things.
I think so. I've got some comments, but Jagdish has got the hand up. So Jagdish, do you want to put your question forward?
Yes, thanks Beverly for a very good presentation. Sorry, you know, I think if you can't.
Like I said, we can't see you. We're just looking at the floor.
The laptop was folded, so you were seeing the table here. So Beverly, you know, in terms of diagnosis of asthma, you have to have two things together to diagnose. So if we considered FeNO as one part of it, then we would need spirometry or peak flow monitoring, things like that. So how are you doing that now that we don't have spirometry in your patients?
Well, I'm lucky because I do. So in my own practice, we are carrying out spirometry, and you know, we're back to doing what we did before. So we have that. Of course, I would say we need three things to diagnose asthma. We need a good history, and I cannot stress that enough, that, you know, we cannot rely on spirometry or FeNO to make a diagnosis. These are aids to diagnosis. They are the icing on the diagnostic cake. They are not the cake. The cake is the history. So we really need to focus in on that. And then I'm looking at sort of measurements of airflow obstruction and then measurements of inflammation. So that airflow obstruction could come through peak flow readings. It could come through spirometry. What really concerns me is, you know, this idea that on a good day you can get normal spirometry. On a good day you may not show evidence of clear reversibility, and that terrifies me, to think that somebody there with a barn door description of asthma who really does, you know, warrant at least a trial of treatment is going to be denied that because the spirometry on the day happens to be normal or near normal. So that's why I think we really need to focus in on the history as being the key element, and then use the tests that we can do, whether it's peak flow, whether it's spirometry, whether it's FeNO, to really, as I say, top off that cake, where we can say, actually, yes, this really does look like it is asthma, and we're prepared to go forward with the trial of treatment at that stage. So that's the way that I would do it.
Right, thank you.
Yeah, I mean, I think that's the point I was going to make, if you've reiterated. I mean, the history is so key to this, isn't it? Because if we don't get the right history, we're going up a particular avenue which is not helpful. And FeNO is not going to be much use in sorting out the management of heart failure. So taking the right history, doing the examination is the key. And then, as you say, the diagnostic is to confirm and support the management. I guess the other thing that you brought out, lots of things in the presentation, and thank you, it was really good. And it was nice to have a verbal presentation and lots of slides, so appreciate that. I think is the fact that we have a biomarker which is readily available for an inflammatory disease. And it is really hard to think in medicine of many biomarkers that relate to symptoms and relate to treatment. And those biomarkers that do tend to be a blood sample, you know, so your CA125 or something like that. In cancer, we have a simple exhale test that is a marker of both disease and the management thereof. Why are we not using this across, across the whole of the UK? It is such a simple test and is so fundamentally important. So I echo what you say, and I think respiratory medicine is in a wonderful position to have a biomarker. The concern is it is not as available as it should be. And I think that's something that we've really got to work on, isn't it?
Definitely. I mean, I think it's one of those things. I love the title of the session that one of my speakers who's following mentioned about, the non-believers. And I think there are people out there, and I confess that in the past I thought, really, you get false positives, you get false negatives, but what tests don't you get those, So it's actually only the same as, if I do an HbA1c on somebody and it's in the diabetic range, I don't take it as being diagnostic. I repeat it because you don't trust a single test like that. If we do someone's NT-proBNP, it can be raised. It doesn't mean they've got heart failure. It's just something that helps us to actually ensure that we are on the right lines with what we thought from the history that we took. This is a fantastic point of care test that I can do immediately. So long as we followed the rules in terms of what they have and haven't done before they have the test. And even if they haven't followed those rules, I just bear that in mind,
Yeah.
I'll bear that in mind. So it's just so convenient. And I really look forward to the patients that I see where I go, oh, do you know what? FeNO would be really helpful here. Whereas, I must be honest, sometimes I think, it's no good. We've got to do some spirometry. Well, okay, let's get that sorted. Not quite the thrill.
Yeah, I mean, I think your positioning of spirometry is also an important one, which I concur that it does concern me that someone has normal spirometry because they turn up for that test on a good day, and therefore they are labelled as not having asthma, and they clearly do. And I think we're enforcing people to do bad practice, hence the importance of the history. So as you say, that's a debate for another day. And unfortunately, QOF remains as it is. But there's always opportunities in the future. So Bev, thanks very much. Great presentation. Lots of discussion. Really enjoyed that. But you highlighted a lovely segue into Sally's presentation. So Sally, thank you very much for joining. Sally's a practice nurse and part of the Solihull group, and has got some case histories. So great, Sally, over to yourself. You've got some slides to take us through the difficult patients, I think, and the non-believers. So over to yourself.
Thank you. Firstly, I want to just say I'm quite new to FeNO, so this has just been my experience over the last few months, and just a couple of cases that I thought were interesting, but typical in how we're going to use FeNO going forward, because we are doing spirometry, but it is limited. We're a 6-site PCN and practice. We were 6-site practice before we became a PCN, but there's only 2 of us that are trained in spirometry, so it's very limited, and we need to save that, we feel, for those with perhaps confirming COPD, or those with diagnostic doubt. And as Beverly said, that, you know, those few that you just think, oh no, I just need that for whatever reason. So I'll take you through my first one, the non-believer. This was a chap who presented to the GP at sort of about 12 months before I'd met him. He'd had a twisted ankle, a football-related injury, and do you want to move next slide, please? Sorry. Great. He happened to mention on the call, oh, I've been getting a bit tight-chested, you know, and the GP gave him a good old Ventolin inhaler, as they do, and not arranged any follow-up. He called back sort of 10 months later, October 22, and asked, you just requested another inhaler, and then somebody booked him in with me. Next slide, please. So it was a telephone review. I don't know if the rest of you are finding this. We're quite happy doing face-to-face, but a lot of our working population still like telephone consultations. So I took, it was over the phone initially, and I chatted through his respiratory history. And in a nutshell, basically, he's 50-year-old. He had been having a nocturnal cough, which was waking him up now several times a night. It built up over the previous 10 months. He was tight-chested and wheezy at times. It was starting to impact, I think, so the weather was turning colder, going out into cold air, all those typical triggers. He did have a history of atopy. He'd never smoked. He told me reluctantly he was diagnosed as asthma as a child. He'd had inhalers on and off over the years. He wasn't convinced that they did anything. He wasn't convinced he ever had asthma, but he was convinced he wanted a blue inhaler. So, right, okay. The beauty with FeNO is it's quick. So I just, look, can you come in, and I'll, we'll go through it. So next slide, please. So in he came. I'd got most of the history down from over the phone, and I was giving him a peak flow diary. I usually keep them for 3 weeks to capture the missing days. His asthma control test was 10, still not totally convinced, but his FeNO was 68. And it was the first one that I did that was raised. So I was quite excited, and he was like, oh, why are you excited? It's like, look, here we go. And when we explained to him that that's airway inflammation, this is what it means. We still have to demonstrate the obstruction with the peak flow diary. He was quite a sort of science-minded, so he liked that. He really liked having that physical reading. So at that point, while I was initiating the diary, I was also starting a trial of treatment on the back of that, with a follow-up 6 weeks later. Next slide, please. So at the follow-up, he had a really typical peak flow diary, so he was swinging up and down. his asthma control test had come all the way up to 23. His FeNO was reduced to 18. He's now feels, well, whether in the long term he'll carry on believing it, but he could see that physical difference, and was more than happy to you know, be compliant with the inhaled steroid. So yeah, we converted a non-believer. So I was quite pleased with that one. And I think also with the FeNO, it's been, for some people, it also gives you the confidence, if you're not sure, to not prescribe. I think there's a big push, but when you're facing a patient, you feel, I don't know, the appointments are hard to come by, you know, and the patients have no hesitancy in telling us that, and you feel you've got to sort it all out very quickly, you know, here and now, and you but actually having physical readings that back up to prescribe or not to prescribe, again, going back, it's nearly all on the history. These things help you with that last decision, but it can give you the confidence when, you know, when it is or isn't needed as well. So I'll move on to my next case, which was, so next slide is caller Susan. This poor lady, again, it was over the telephone initially. She'd had basically in the past 12 months, she'd attended A&E 3 times with acute episodes of shortness of breath and wheeze. She was told in A&E, oh, I think this is an asthma attack. They'd given her a nebulizer, but nothing else. Did you go and see your GP? She saw a GP about 12 months ago and was given a peak flow diary and told to follow up with one of the respiratory nurses. But she's a busy mum. She's got 3 under 5, and 2 of those are twins. She'd had a miscarriage in that time. She's moved house. She's just not her main priority. I basically took, she'd lost a peak flow diary in the house move. So when I was talking to her at this stage, she'd taken to, now she sleeps on the sofa. If we go to the next slide. So she could, because her night cough was interrupting her sleep to such an extent for her husband, her children. She's sleeping on the sofa. She does have dust mite allergy, but she'd never been diagnosed with asthma. She's never smoked. She said she's not really had any chest issues in the past, but colds do always go to her chest. It was the nighttime symptoms. I think she was just at the end of her tether. So obviously at this stage I'm suspecting asthma, and again I slotted her in between other patients. She said, can you quickly come down? I thought I need to get this lady. She brought in her peak flow diary, which was like a cartoon going from 300 to 600 with a diurnal variation every single day, this poor lady. Her asthma control test was 8. If we go to the next slide. So did her FeNO, as I say, it came up at 300. So I was, oh my goodness me. That was, again, being fairly new to it, that was quite a shock. I was expecting it to be elevated, but not that much. So I think when I reflected on on it since, I put her straight onto, and I would never have had the confidence to do this without that FeNO measurement, but I've put her straight onto high dose steroids, and combination inhaler, with a view that I was going to review her and hopefully reduce the doses down once her levels are more controlled. I kind of got excited and sent her the asthma control test after about 4 weeks, and it had already come up to 23, which was a massive improvement, obviously, in her quality of life. And I brought her in, if we go to the next slide, I had no idea how quickly or I could expect the FeNO to be reduced, but I repeated FeNO, and this is after about 7 weeks on Monday, and it's now 85, so still very high. So I'm keeping her on the high dose, but her symptoms, she's back sleeping in a bedroom. She's just said, in her words, it's life-changing. And as I say, just for me, I just would never, without that physical reason, wouldn't have had the courage to put somebody on a high dose combination inhaler straight off. Here we'd have probably done the old starting, with the old beclometasone and building up gradually. So yeah, I found it quite a revelation, really. So that she's been the highest one I've had. And that's it in a nutshell.
I must learn to stop unmuting myself. I think that's really helpful, Sally. Thank you very much. That sort of naive experience that you had, I think a couple of things come over from that. That kind of enthusiasm that you had from that positive result and how you made a difference, I think is something that Bev highlighted, wasn't it? That sort of excitement of finding the result. And it's that sort of feedback, isn't it, that you think, yeah, I think this is asthma, but let me just check. And that giving you that confidence to confirm your clinical history and examination, it is so important, not only for you as an individual, but as you highlighted in the first case, for the patient, isn't it? And there are lots of non-believers, and I think that represents a really difficult population to manage, some of which I'll see in secondary care, that, I don't use these inhalers, they're rubbish, they never work. The GP's given me lots of them, they're no use at all. And actually what we can find is do a measurement and show them that this is what the issue is. They listen to it. And it is often that sort of scientific individual who responds to that. The other thing, just as an anecdote, I really smiled when you said they lost their peak flow meter. For someone who's supposed to do a test twice a day, it's really interesting how often people forget to do their peak flow meter or lose it. At least they're honest enough to say they've actually not done it, but just not brought it in. So I did smile when you said it got lost. That seems to be a regular finding. I think we have a question, and that is from Sharon Blois. Sharon.
Hi, I'm not sure whether this question was for Beverly or for Sally, whoever can answer it.
Or for both.
It's just that in the last week, I've actually had two patients. I am doing spirometry. I've had two patients who we've diagnosed using spirometry and FeNO, and they've had high FeNOs, and they've got asthma, and they've gone off with their Clenil, and then they've come back 6 weeks later. And in one case, the lady's FeNO is actually slightly higher, and the other lady, it's not moved at all. So it's just, what are we supposed to do with these patients? I mean, one of them, she was only on a lowish dose, so I've upped her steroid to the max, but it's just, what do we do with people once we've done them, and then we review them, and then we review them, and then they're still high? I mean, I don't know what the care pathway is now.
Yeah, I mean, I think Bev is probably with the best experience to answer that. I mean, my first thought is, are they taking it? But and what's their issues around adherence? But
yeah, I
Bev,
think they're both taking it. They're very, quite.
Bev, you're the experienced one here.
No, I think we can both share. I mean, I would be looking very, very much at the symptoms. So I'd want to know, because, we've said that none of these tests, none of them are diagnostic, none of them are used in isolation. So I'd be really interested to know whether resolution of symptoms had happened.
Yes, it has for both of them. They both feel better.
So
they're both feeling better, but it's just, do we escalate and go up to MART? I know you like MART anyway, but do we just escalate to MART so they're getting that little bit extra steroid to try and get it better than it is? Or
I would always say yes to that. And one of the things I was going to say is that I wouldn't start them on Clenil. No, absolutely no reflection on Clenil whatsoever. Great drug in the right place, ideally in children, I would say, but certainly, we need to be thinking dry powders, and I'm, as you say, a huge fan of MART. It really does give people the potential to self-manage very, very effectively using human nature mixed in with the science. So, but I would be hugely reassured by the fact that their symptoms are better. It may well be that, you know, that there were things that were impacting on the test result the first time or the second time, you know, that they haven't perhaps realised things that they've done or not done. I honestly would be very, very reassured by the fact that their symptoms were improving. Might look at some lung function, as in what's happening with their peak flow readings if they're doing them. But, you know, let's not lose sight of what's really important here, is that you've got a patient who was struggling, who is now, you know, relatively symptom free, and that's what we should be aiming for. And then, of course, the opportunity may come for withdrawing that treatment in the way that the guidelines recommend, to see what happens when they're not on that treatment again. So, you know, don't despair because that reading isn't going in the direction that it would go 99% of the time. You've just been a bit unlucky.
I've been unlucky, I think, with 2
Yeah,
in the last
absolutely.
week. Yeah, that's fine. Thank you.
Sorry, Holly put a comment in the chat as well, which you reinforced, Bev, about how we use FeNO as well to step down treatment. And that's the important bit that Kerry highlighted, which you mentioned, by withdrawing treatment or sometimes stepping down. In her service, she's saved approximately £12,000 in a year just on the drug spend, let alone all the potential for the greener environment. So real opportunities there. That's great. Thank you very much for both presenting those really interesting case histories, and Bev, your journey of how you started and where you got to, and Sally, your kind of early start of what you found and your experiences. And I think that's something we really want to bring forward, because we're all learning with this. Some people have been using it for a bit longer, but we're at the start of a crossroads about how we fundamentally change asthma care. So thank you very much for those. There are no more questions. So, Andrew, do you want to tell us a little bit about the prospects we've got of expanding the use of FeNO and the 300 project?
Yeah, I'd love to. So I'm going to share with you an offer by Circassia, one of the FeNO companies. They've offered to provide 300 devices, but that's to share out nationally. So that means that we've got 37 on offer to the West Midlands, which is great. And they're really trying to get every ICS, so we've got 6 ICSs in the West Midlands, to about 50% capacity with FeNO. So it's going to make a really big difference. But the offer is to where there's no access to FeNO. So if you're a PCN, you want to adopt FeNO, please do get in touch. We'd like to hear from you, and ideally to PCNs in deprived areas as well as a priority. But their ask is that whilst they'll give out the device on loan for 3 years, that the PCN will sign a memorandum of understanding to purchase a minimum of 100 mouthpieces for 3 years. So in year 1, you have to purchase 100 mouthpieces, in year 2, 100 mouthpieces, and in year 3. And they're approximately 1,000, just a little bit of £1,000 for 100 mouthpieces, and less for 300 mouthpieces. It's just under £2,000 for 300 mouthpieces, but they just want you to buy the minimum. And they've got a brilliant portal. It's ever so easy to set up. They've got a portal that you go on, you register, and you can read the memorandum of understanding and see what you're signing up to, and you sign, and then they'll dispatch the device. We are very grateful to Circassia, because we actually used them in this in our FeNO project. And what was excellent was the minute we asked for the device to be delivered, they then contacted all sites and offered face-to-face training on how to set up the device and just how to use it. And then following that, they also, in fact, you can actually book it on the portal. You can book a clinical masterclass with their with their nurse. The devices, they do vary between the different devices. I think this one's about £2,500, if I remember correctly. So all in a kind of, in essence, you almost get to try it for 3 years without buying it. But I think their offer is really genuine, and if their sites are using it, obviously I can't say this, guarantee this because it is down to the MOU, but I don't think they're going to pull it away. I think if you continue to buy the mouthpieces, they'll leave it with you. So I think this is a great offer to increase the uptake of FeNO. So if you want more information, do just pop me an email, and I'll send you the details that we've got. So, but I'd love to think, in fact, I'm really excited to see some huge areas with about 28 PCNs who've currently just got 2 devices in their whole area, kind of going up to potentially 14 or 15 devices. So, because can you imagine the benefits that we'll have to so many more patients? So I'm really keen to try and encourage the uptake of these. So please do get in touch.
Thanks very much, Andrea. So I think this is a great offer. There is the caveat, obviously, of needing to buy them. But if we go back to the comment that I made in response to Bev, actually, you are likely to save that money on the actual spend of drugs by using them more appropriately. So there is probably, if you do a true economic balance on this, it is a cost saving, let alone the patient benefits, etc., which we've heard today in the presentations. Andrew and I have actually writing to all of the ICB boards as well, promoting this, suggesting that this is something that they take an element of ownership as well. So we're really keen to try and promote this, and we will support you at PCN level, at practice level, as much as we can, fulfilling those targets of the deprivation. And as you said, Andrea, the training comes free from Circassia. And of course, we would like to welcome you into our community of practice if you do join. Just to conclude, what we aim to do with this, we're starting this. So we are developing this community of practice, and we aim to have a newsletter that comes out every 2 months, and we alternate that with a more formal presentation like we've had today. So we've got a plan and a date, I think, for the next formal presentation, and we've got some people who've lined up to speak, so thank you very much for those individuals, and we will be releasing the newsletter fairly soon with regards to that. That's perfect. See, Andrea, that's perfect, Andrea Claire, for actually showing what we've got coming up next. So we're just about on time. Are there any other final comments or questions? There's quite a lot in the chat, and we will look through the chat and try and answer any specific questions on there, but I think we've picked up a lot of them as we've gone through. I can't see any hands appearing. I think what is clear from the chat for both Sally and Bev, how much your presentations have been appreciated, and no doubt you can read that. So thank you very much for taking the time to come and present your experiences, your findings today. Very well received. Thanks very much. And Claire, Andrea, thank you very much for kind of hosting this and putting this together. We will organise a date and let you know when the next one is, as we've said, and we'll be in touch with the newsletter in the near future. If there is anything that we can do to help support you in this community of practice, just drop Andrea a note and we'll do what we can to help facilitate that. And thank you all, and have a good rest of the day. Bye all.
Bye. Thanks everybody for your participation as well. Have a really good afternoon. Thank you.